So if one thinks about molecular testing as an adjunct to what we have used so far for diagnosis and prognosis of melanoma, one needs to be very specific about what type of molecular testing. For example, testing for BRAF is routinely implemented, and we know that patients that have BRAF mutations will respond to BRAF inhibitors and should probably receive those. Patients that don't have those mutations will not. In fact, might have quite the opposite effect. So that type of BRAF testing, where molecular testing, where one has a very clear decision tree, is something that has been implemented and should be used. If we expand broader from that, usually we are talking about situations where one is looking for potential other targets that could be attacked with current therapeutics. There, the decision tree is less well defined. And that is one of the reasons why we launched into this type of a trial and project to really not only test the hypothesis, can we treat patients by directing the therapy based on molecular findings, but also how to do this best. What are the best practices if one is to do this? How do you interpret the data? What kind of data? Do you use partial sequencing data? Do you use the whole genome sequencing data? There are pros and cons of both. In Stand Up to Cancer Melanoma trial, we are using fairly comprehensive sequencing, fairly comprehensive molecular analysis. And this is not based on a panel of preset number of genes. This is really sequencing the entire genome in form of an exome, which looks at sequences of all coding genes. We also include what we call long insert genome sequence, which allows us to capture in a very efficient way some of the structural rearrangements in the genome. For example, fusions of the genes and things of that nature, inversions of the genes.